All right, we're recording. Let's begin. So we're talking about important stuff here to the limited number of people who have made it today in the cold. No, it's okay. It's okay. I'm not going to get excited any more than is absolutely. I'll have to leave the phone on because in case they call. They want my number in case they call me. But okay. The most common kinds of infection, even though they have a picture of a child, and you can see when you see purulent or pussy drainage, that almost always points to bacterial. So for many of you, you'll see a lot of conjunctivitis. You may have had some in your family. It's very, very contagious. Again, for all of these, whether it's pink eye, conjunctivitis, otitis media, middle ear infections, or a variety of sinus infections, typically they're 1/3 viral, about 2/3 bacterial, and more often than not, they start viral and then they go to bacterial. That's really part of the problem. And I mean, and you really judge about the drainage that's there. You judge about the intensity of the pain. And bacterial are inevitably require antibiotics. And it's really there's a commonality to it, and this is the commonality. There are other causes. The vast majority are things that are normal to a certain extent. Haemophilus influenza, so named because they thought it was the cause of the terrible flu epidemic, because they didn't know from viruses or bacteria. But they found this commonly in people they tested and did gram stains of people who were dying of this, arguably the worst infectious disease epidemic of all time, the Spanish flu of 1918 and 1919. And everybody had that. The thing is, it turns out it was normal flora. In other words, normally there, but they named it Haemophilus because of what it did, on blood agar, as you have used in the lab, and influenza, but they turned out to be normal. Now, interestingly enough, we know that this is a cause of meningitis, bacterial meningitis in children. Okay, and so you'll see an immunization, and I assume it's still on the schedule. I think this is one of the ones that the CDC is now not calling mandatory or recommended versus optional. HIB, which stands for Haemophilus influenza B, whatever the B strain is, seems to be more common. So I'm aware of that. I do not know if that is still on immunization schedules for children or not. And again, the other one is Streptococcus pneumonia, which arguably 1/3 to a half of us harbor normally. Those are the big players. One, Haemophilus influenza is a gram-negative rod, very easy to kill. Streptococcus pneumonia, which you're already aware of, Streptococcus is a gram-positive cocci and streptococci. And strep pneumonia, just because it's part of this chapter, has 3 different names. It's all the same thing. Sometimes it's called Streptococcus pneumonia. Sometimes it goes by the name just pneumococcus. And another name that it goes by is because it's typically in pairs rather than chains, Diplococcus pneumonia. They are all the same thing. It's just depending on who's talking to you about it, you'll hear 3 different names. But the reality is, this is a relatively easy to get rid of gram-negative rod and a relatively easy to get rid of gram-positive cocci. And that's why, with the research being done here in Pittsburgh for all of these, whether it is, and again, for conjunctivitis, you're always going to be using antibiotic drops are part of it. And there's a variety of different ones that are used. There's so many. I'm not going to go into all the topical aspects of that. The topical drops that are there, the combinations. But typically what we use is amoxicillin. If you're not, and again, we would go to an erythromycin if they were not, or a Z-Pack, because amoxicillin, it broadens the spectrum. It's effective against gram-negatives that are relatively easy to target, like Haemophilus influenza and Streptococcus pneumonia, which is comparatively easy. The only time we change that a little bit, sometimes we will go to augmentin in cases where there might be a beta-lactamase producer. But you can see, these are all very, very similar. Respiratory droplets, contaminated hands, much more common in kids. Okay. all the things it can do. And I mean, and believe me, this is not something, it's so easily spread. I can remember families, because you're always kind of, when you have little kids, you're friendly with other families with little kids, and they're ping ponging this around, kids to kids. If one of our kids got conjunctivitis from wherever they were, I mean, everybody's, not only were we starting the kids on drops, we were starting each other on drops. I mean, just better. Same thing with strep throat, same thing. If one kid was getting it, the next thing you know, everybody's getting amoxicillin. Maybe that was the incorrect thing to do, but given that I had a prescription pad and I could write prescriptions, it was fairly easy to do that stuff. But it seemed to work all right. So I'm not saying that's the appropriate therapy or something that you should be doing the same thing, but it is, realistically, these are highly, highly contagious. And the one that surely I think has the most problems going forward is this, and that's the middle ear infection. I mean, depending on the severity, a sinus infection may have to be opened up. It's a kind of surgical procedure. This is another one that sometimes requires. We start with antibiotics, not topical, oral. Topical antibiotics would be into the external ear are going to be blocked by the eardrum. When otitis media is the inflammation in here, whether this is narrowed, whether it is filled with pus, whether it's inflamed, sometimes structurally, more children are more prone to them. I talked about the fact that the angle not being down the way it's pictured here, but much more horizontal, is mechanically is going to lead to a greater number of these in children. Okay, it damages the ciliated cells, etc. It collects, and what happens is it's a drumhead. Drumheads are, when you are going to learn, many of you, how to look at an otoscope, the device where you can see the eardrum. They're going to have like a little, what I would call an atomizer, a little rubber ball that you blow air into it. And what that does is you look for the vibration of the eardrum. That's what you're. If it doesn't vibrate and it hurts, it suggests that something is creating pressure and making that drumhead more rigid. That's effectively where the pain comes from. And if it's being pushed on enough, it can rupture. And that's the problem with these. So when there are a lot of these, the old days, it was like 7 to 9 of these in a year. My daughter, on 2 occasions. What happens is, and again, biofilms would form depending on the combination and the nature of the particular organisms. They would insert a myringotomy tube, fancy name for a tube. You can see what this is, a ventilation tube. It's like got a mushroom cap here, and it's got a hollow area there. So it's got basically the rubber portion of it keeps it open. It's very tiny. And the cannula, the opening, the hollow area through and through, allows ventilation. In other words, relieves the pressure. And what happens as it heals from within, it kind of gets pushed out. Okay? So as the healing goes on in the middle ear area, it pushes the tube out, and out. And you don't have to, in other words, it's a very, very quick surgical procedure. You put the kid to sleep, 2 little nicks, pop in the tubes, 5 minutes, wake them up. And then you put them to sleep, they start waking up. That's how quick the procedure is. And what will happen is over time, within, I don't know, maybe let's say a month, 2 months, for argument's sake, I do not know the time, what will happen is it will just basically pop out on its own. Sometimes the parents will spot a little bit of drainage on a pillow. It may happen in the shower. You don't even notice it. It'll just go down the drain. And sometimes I'll actually see this little rubberized, sort of lift it up and go, I wonder what this is. If it's a little rubberized tiny tube with a magnifying glass, you'd be able to identify what it is right away. You know what you do with it then? Underneath the pillow. Tube fairy. Makes sense, doesn't it? Doesn't it? But tell me that you didn't put your teeth under. Mom and Dad didn't do that. Didn't they? See, you're normal. I know. Yeah, pardon me? That's what I'm telling you. It probably wasn't your parents. It probably was. And that may be a pejorative term these days. The two individuals. We don't want to use the other term because it has connotations. We have to be politically correct, right? Hmm. Well, and he's the monitor. See, you're privileged to be here for that routine. I do that routine. I've been doing that routine for 20 years. It doesn't get old. We're not done yet with that routine. We're going to revisit that once more before the end of the term. You don't have to thank me. It's all in service. Right? You're good? Didn't you find that was humorous? Didn't your teeth go underneath Kagan? Your mom and dad, they didn't believe in the tooth person. It's okay. It's okay. It's all right. I mean, it was my eldest with his MBA. He got an MBA. He would negotiate. That quarter is insufficient today's economic standards. 5 years old. You're not accounting for inflation. It's ridiculous. He wanted a cost of tooth escalator in his clause. Moving on. So all of these things, very, very important. Again, viral illnesses very often give the way. The vast majority of these alter the mucociliary mechanisms. Okay, common in early childhood, pacifiers play a role. Look, I'm not telling anybody how to raise their kids. Okay, so and older children really beyond age 5. That's where my daughter had 2 sets of tubes, one at age 2, one at age 4. I mean, thankfully her hearing was unaffected. All of these play a role. I never smoked although I was a heavy smoker, I never smoked in the house, but you bring it in. It's on your clothes and things like that when someone's a heavy smoker. So maybe that contributed to it. All of those things are part of it. I mean, for me, when I see pacifiers in 3 years old, it kind of like, when the older kids, it's like, I'm no authority on that. Just I kind of look at it and go, that's probably not a great idea. Okay, antibiotics have to be properly used for all of these types of things. Okay, not indiscriminately, but if you know it's an ear infection, you see the redness and the inflammation in that area. If you can associate with drainage historically, I mean, it's you've got to treat it appropriately. Whatever is right now, I think appropriate use of antibiotics would indicate the old story with hand washing, don't touch eyes, and again, all of these things. And some of these, whether or not they're still utilized as much today, I don't know how many times they're using the tubes today as they were. Again, that HIV vaccine and other vaccines, exactly as they mitigate this sufficiently, I do not know what the current thing is. But I mean, this type of thing, if you're going, particularly in nursing, if you're going into peds or something like that, you'll really understand what's going on with regard to this. Both of those, my oldest and my youngest, both had their tonsils out. I'd say prior to age 10, because they became sources of infection because of the recurrent ear infection. My middle one didn't have that kind of problem, fortunately. Strep throat. The interesting thing about this, the take-home point, it's not the damage to your throat. Your throat will get better. The problem is, this is the classic example of what we call indirect. That's part of that unit that you're doing self-study on. There's direct damage, toxins, growing on a particular surface, altering it, okay, and indirect. Indirect means your immune system is doing the damage. This is the classic example. We've all had a sore throat. We know what it's like. You saw that initial illustration or image that they had in this particular unit, where you can see the tiny pustules and the significant degree of the throat is red. You usually see tiny little pustules, little whiteheads that are there, tiny hemorrhages, blood vessels that are broken. Okay, and typically it's self-limiting, meaning it goes away fairly easily. The problem is not that. Here's the blood auger example, growth with hemolysis. Here are the cocci and chains using an indirect method. Basically, this is fluorescent imaging. Beta hemolysis, group A, different strains with group A distinguished by certain kinds of M proteins. That's how they're part of the identification process when you get elaborate. This is what it looks like on the exterior. all we're looking at, you and I both, we sit there and we see, oh, it's a cocksucker. We see this under the microscope. It looks pretty interesting. It's a little dot. Understand when you look at it from a microscopic, look at all the different things that are projecting. Here's the membrane. Here's the peptidoglycan. Here's all the stuff. M proteins, different types of proteins, lipoteichoic acids, a capsule, particularly problematic when you're dealing with streptococcus pneumonia. Okay? And so the good news is that antibodies can attach to this, okay? But there's very strain dependent. Some strains are resistant to. There's all sorts of enzymes that this produces. So these basically are the way it does some degree of primary damage, direct damage rather than indirect by the immune system. Breaking down DNA. Hyaluronic acid is part of connective tissue. This breaks through it. Proteins that breaks through it. Streptokinase for years. When someone had a blood clot, and they recognized a developing stroke or heart attack, you could get it before there was significant damage. They would inject streptokinase, a clot buster. We now make it generically. You did the blood unit, right? Did you talk about TPA, tissue plasminogen activator? Ringing a bell? The clots are made, and then we break down, we bust our clots with our blood vessels would be clotted a lot, particularly the small ones. Is this ringing a bell? Maybe not. Okay. TPA is what's now made in the laboratory, genetically modified material. So we make it in the laboratory, and basically it's what we use, what our body makes to break up clots in tiny blood vessels that basically are being repaired all the time. So we no longer use the streptokinase, just for informational stuff. You should know about TPA. I forget the name, but it's something that can be used in a lot of hospital emergency rooms have this, and they can introduce it by a catheter and stop a stroke or stop a heart attack in its tracks if they get to it fast enough. Something my late aunt had done when she was in Florida, because Florida, they have a lot of elderly people. Most of the hospitals are on top of this type of thing. They're looking for strokes and heart attacks because you're dealing with an elderly population. So all of these things, this is the big deal. The pathogenesis of Streptococcus pyogenes, post-immune system. The capsule presents a problem that's there. There's a lot of different immunological things. Okay, these are some of the ways it does its damage. And without going through all of these are just some of the things that it can do. Okay, and so immunologically, the complications we'll get to in a second. These are called SPEs. Streptococcal pyrogenic fever-producing exotoxins. Very high fever, one of which is called scarlet fever. Scarlet fever it comes about it produces what's called an erythrogenic toxin. Okay, that's one of these that you can see them discussing here. The other one, so toxic shock. So they are toxic shock, as well as staphylococcus, which is more common. Toxic shock toxins, and lastly, flesh-eating ones. All three of those. They are, by definition, super antigens. They activate 20% of your helper T cells. Helper T cell is the single most important cell in your immune system. When they activate them dramatically, they produce a slew of chemicals. We refer to that as a cytokine storm. And basically, the nature of the immunological response is potentially and frequently deadly. So we have different things. So most of you wouldn't be familiar with scarlet fever, scarlet fever prior to the age of antibiotics. And the whole idea is to treat with antibiotics early on. These are cases that are either not treated or undertreated. There's a sore throat that people go, it's just a sore throat, get over it. We'll get some cough syrup and whatever, some Tylenol. So when you don't treat these or don't treat them sufficiently, this is the kind of thing that will come, and it's immunologically based. This cytokine storm is potentially, and again, frequently lethal. So erythrogenic, the body you get it's red, and you'll see some illustrations of this. You'll see more pictures of it when we look at skin. So it kind of overlaps into like skin disease because of the way it appears. But internally, I knew a guy who lost all of his hair when he was a kid because of this. People have lost their hearing because of this. People have died frequently. This is one of the great killers, probably, prior to the onset of antibiotics. That's one. Toxic shock syndrome. Did you guys ever hear of that historically in 1980? It came from tampons. We'll talk about this in wound infection. In 1980, it was OB, was the brand name I recall. And they came up with what was called a high absorbency tampon. So you didn't have to remove it that frequently. The trouble was the nature of the construction and the material. It became a culture plate for certain bacteria, more often staphylococcal than streptococcal, but both. The staphylococcal ones were even a greater toxin. Women were dying. They stopped using tampon. Usage fell dramatically for about 2 years until the study showed it was that particular tampon. Then it came back. I mean, they were looking for a convenience, not realizing that leaving something like that indwelling that was absorbing all of this as well as the bacteria created just a storm of activity. That's two. And lastly, the very famous flesh-eating disease of streptococcus. Yeah, this is your immune system. And a fancy name for that we have not heard is called necrotizing. When you necrotize, it turns everything into liquid mush, fasciitis. And so in between the skin, which is typically not affected, and the bone that's not affected, all that area inside kind of turns to a liquidy, messy kind of mush. Tendons, ligaments, muscle, fat kind of just turns into yuck. Okay. Liquidy, pasty. Think of something disgusting. It's not that often. It always gets a lot of ink. It's the kind of thing they publish. We probably see less than 200 cases a year in this country. It's comparatively rare, but oh my God, the flesh-eating disease. The reality is you don't see that often. In my career, I have seen 2 cases. You might remember I talked about it a little while ago, and one of the things associated, one of those, and I did it in the context of this, it involves somewhat devitalized tissue. Remember we talked about microaerophilic organisms? They don't do well with a lot of oxygen, but if there's just a little bit of oxygen, they thrive. The microaerophilic organisms, this strain of Streptococcus pyogenes, and it's an unusual strain, thrives in that. I saw one in a drug user, IV drug user, who got infected. They use, you have to understand, they'll use any needle they can get. This is back in 1978 or so, like that. And I saw one that happened, unfortunately, to my ex-wife's uncle, who was a diabetic with very, very bad circulation. They got to him fast enough, they didn't lose his leg. He did lose his leg. He didn't lose his life. It is extremely severe. We'll take a look at that also in wound infections. So these are all really interesting things, and we're not done yet. Okay? Respiratory droplets, contaminated food, humans, nasal carriers. Okay? We see some that when they say anal carriers, it comes out in feces. And again, in hospitals, that stuff gets spread around alike. Individuals can be asymptomatic carriers, some long term. Usual tests we use, throat cultures. Again, for the most part, penicillins, if you're not allergic, are still very, very effective. There is some more resistance to these, but it's still a useful drug. Not done. These are what we call post-streptococcal sequelae, short term for complications that develop after streptococcal infections. Immune, not thought to, they do. Acute rheumatic fever, 3 weeks after recovery. Here's a limited number of strains. Rheumatic gets its name because it inflames the joints, but it also targets and more severely heart valves. When people have heart murmurs, sometimes they're born with them. Years before, again, before we were aware of what caused these, and we didn't have the abundance of antibiotics to be able to use, these were the major source of causing heart valves. When heart valves are damaged, you did a cardiac. The valve is a nice little flap that's got the same lining as the inside of the heart, called endothelium. Same lining as the blood vessels. When it gets irregular, okay, basically murmurs are a sign of turbulence going over those. Turbulence makes little bits of blood clot and adhere to those valves. When you have bacteria that get in your bloodstream, let's say when you eat, when you brush your teeth, when you have teeth cleaned and scaled, there's a lot of ways that bacteria get into our circulation. A lot of infections that happen to get a little bit in your circulation, which do not cause big problems, but they can settle on the heart, on the valves. You get a thing called bacterial endocarditis. That's an infection of the heart valves, and it starts seeding the infection all over. It is a life-threatening infection. That's what this leads to, the sequelae. So an example of this rheumatic fever, when it's acute and damaging not the joints, but chest pains, rashes, nodules under the skin, this is all a severe inflammatory response. Severe enough that we'll see what we call chorea. When it's spelled like that, means herky-jerky movements. Typically, when in the old days, Huntington's disease was called Huntington's chorea. Choreiform movements. We used to classify diseases by the nature of the movements. 30 to half, nearly half, a third to a half, chronic disease, heart valve damage, endocarditis. Okay, we see that there's certain genetic markers, autoimmune response, 3% of severe untreated cases, 10 to 20 million cases globally. This is about 8 years ago. Globally is the key answer. We don't see this when we have, a relatively speaking sophisticated healthcare system like we do in this country. Say thank you. Voila. We're not done yet. So what do we got? We have erythrogenic toxin. I'll talk about that. My dad's mom in 1927 died of a variation of that called erysipelas because he didn't have antibiotics. He was 13. He had a twin brother and sister, fraternal twins who were, 3 or 4 years old. He and my grandfather raised them. No mom, depression, not good. Very difficult. Erythrogenic toxin, that's an immunological. Toxic shock, that's immunological. Flesh-eating disease, that's immunological. They're all part of that. Here, this is, and we're going to see this with skin infections as well. The skin infection, where it's much more common, is called impetigo. We will get to that in skin infections. You will see a ton of it. Most of the time it's staphylococcal. It doesn't do this, but the streptococcal one, okay, causes autoimmune complexes, antigen-antibody complexes, where the antibodies can grab onto the streptococci, but they clog up the kidneys. They're just not easy to dispose of. And when the kidneys shut down, you get fever, fluid retention, high blood pressure, and because of the damage to the glomeruli, which you probably didn't get to kidney yet in A&P, is that correct? Who's doing it now? The glomeruli are the filtering apparatus. When the kidney has one response to anything goes wrong. Infections, backup, not enough blood pressure, it shuts down. What the sign is the glomeruli is blood and proteins which should never be in your urine start to come out. Okay, inflammatory reaction, antibodies bind, blah, 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 blah. Only a few strains do this. Most of the time we see it from impetigo, skin infections. I've known several people with this case. Not the only one. My stepson, who taught here, I've been taught here since 2021, taught physics here. graduated from here. When he was in high school, he got this after a strep throat. So sometimes it's after a strep throat. Normally it's the skin, but it doesn't preclude the strep throat. All of a sudden, he's supposed to go like on a band concert thing down to Florida at Seneca Valley, where he went to high school, and it's like, oh my gosh. Fortunately, it eased up enough that he could still make the trip once they got him in the antibiotics. We're sitting there, and the doctor, our old family doctor, he goes, this. Have you had a sore throat or a strep throat? We said, yeah, I think I had one about 2 weeks ago. Bing, check please. Right then, that was the diagnosis. So they're just showing you, these are nice little charts that you'll see in this particular PowerPoint. The usual things, appropriate antibiotics, all this typical stuff that we're familiar with. Watch out for people with history of certain kinds of diseases, etc. A lot from something very common. So now you have the typical upper respiratory viral and bacterial infections and the very famous sore throat. Here's one you're not going to see, hopefully, ever. Diphtheria. This is one of the 3 immunizations when you get, there's another one, you get 3. You get a tetanus shot, you get immunized for tetanus. You get immunized for pertussis, whooping cough, which we're going to get to in this unit because it's a lower infection, more of a lower anatomical respiratory infection. And diphtheria, which is upper. Diphtheria is so severe, was so deadly, that was one of the earliest ones that were identified. All of those 3 make toxins, and to make the immunization, we are able to take these toxins, which are proteins, heat them, and what happens is destroys their ability to hurt you, but if you eat them just right, the proteins will denature, but it'll still have enough to trigger your immune system to make antibodies. That's how it works. So they're called toxoids. It's a triple toxoid or a trivalent immunization that we all get, and we all get all the time. You'll be, one of the first questions you're going to ask in a clinical setting, when was your last tetanus shot? Did you get all 3? Okay. That's the short course. Diphtheria is extraordinarily scary. It's the only one of these upper respiratories that's so immediately life-threatening and deadly to the point where it's scary. Anecdote coming of significance. It creates a toxin that attacks your lining of your throat, causes, you'll see the description, it basically causes it to heap up and either break off and clog your breathing, and in the meantime it's producing toxins that affect multiple systems. So not only can't you breathe, you're also in extraordinary pain. Okay. So this is the one, it's very rare now. This is the one I have some information about. This was in Siberia, the old Russian Federation, newly independent states of the former USSR, just after basically the termination of quote-unquote communism. 125,000 cases with 4,000 deaths. My very first micro class at Chatham, nearly 25, so this was 93. The gal who was in my class was at Shadyside School of Nursing. She was already a medical doctor. She was in a psychiatry residence. She married a U.S. GI. They had a kid. They came back to this country. They wouldn't transfer her MD degree so she could go into a psychiatry residency, Pittsburgh or anywhere else. Money was tight. So she said, I'll come. But nurses were making good money. So she said, I'll just go into nursing school, get that, work there for a couple of years, make some money, and go back and take all the tests that would allow her to qualify as an MD. She was there. We had a class of about 55 or 60 people at a big teaching auditorium in Chatham. We all sat there as she described when she was doing her training in Siberia. This people writhing on the floor, couldn't breathe, in extraordinary pain, dying as you looked. As she described it, our mouths are going, mine included. Why? Never heard it. The scariest descriptions you ever heard. Perfectly clinical because she's a doctor who happened to be going to nursing school because of just the situation of the licenses not being obtainable at that point in time in our country. So this is how it worked. Starts, and then all of a sudden, fever and fatigue, don't feel good. This is called a pseudomembrane. This is from the toxins that cause the direct damage where you breathe. And then all of these other toxins, heart, kidney, nervous system, she described all of this to the point where you're like, oh my God. When you look in the labs, if you saw gram-positive rods that were endospore negative, and you should have seen them on some of your slides, which you did, particularly if you did environmental samples, they are called Corynebacteria. We call them diphtheroids. They're normal. They're on your skin, they're in your throat, they're everywhere. Okay? So when they say pleomorphic, it has a variety of different shapes, and it typically stains in these, we used to call it a Chinese letter pattern. Classically, now we call it palisades because they stay somewhat attached. And it looked like those, like the Chinese letter characters, the Asian characters you see, like at a restaurant, when they see that. Okay, the toxin, again, caused by a viral infection of the bacteria, difficult to isolate. These are not easy to grow. That are there, doesn't invade, but the toxin, pseudomembrane, loose and obstruct airways, toxins. I should have said this. Thank you for reminding me, Lou. On that self-study unit, it didn't have this question on the test. I think the test is going to be around Thursday. Okay, tentatively set up for called AB toxins. It's a two-part toxin. A is the active part. That's the toxin. That's what does the damage. B is the binding part. So what happens is the bacteria secretes them. They join together. The binding part attaches to the target, like our lining cell, and then it opens the door and allows the active part to enter. So, I mean, it's just the way that they're called AB toxins. We're studying them because we might be able to attach a way of destroying a particularly bad tissue, like a cancerous tissue, with one of those binding markers. So every time we have something that hurts you, it's like snake venom. When you have something that hurts you, you see how it hurts you and then how we can use it. That's, I mean, science does it all the time. We take something that's potentially deadly. If it does damage, how can we damage stuff we want to damage? So, I mean, that's the interesting thing about medicine, why toxicologists are why it's such an interesting field. If you're looking at things like snake venoms and bee stings and all that type of stuff, which I know it's not that funny. Thank you. It's only 4 weeks. We'll be fine. I'll stop having, I don't drink anyway, so I don't have to worry about stopping drinking. Yeah, they're supposed to call me back. 10 more minutes. Anybody see that phone ringing in this freezing room? Not a blanking chance. See. Not, okay. Human to human. I wouldn't worry about cutaneous. This is the toxins are, antibiotics can clear it. The problem with this, the problem with tetanus, the problem with diphtheria, the problem with pertussis, the toxins, once they're there, antibiotics don't help you. You have to have the antitoxin. So if you get to somebody with these, the appropriate treatment, even for tetanus, you've got to address the toxin before the toxin causes permanent deadly damage. Okay, even with treatment, if people who are unimmunized, a 10% mortality. Okay, gives you an idea. Same deal with pertussis, with whooping cough. In infants, if you don't get to them soon, it has a very, very high death. 10% is a big death rate for something ordinarily you could treat with antibiotics because the toxin works faster than you can get a hold of it. All the others, we all get viral infections, common, lots of different kinds. Most of the time, they're rhinoviruses. Some are adenoviruses. Normally, our body's defenses will take care of them. The problem is secondary bacterial infections. I mean, I don't know about you. when I was a heavy smoker, I was more prone to those. I'm not now. Just like you, I get a cold, a couple of days, gets better, I'm happy. I'm miserable with it. My wife doesn't want anything to do with me. Doctors make the worst patients. You will see this. We are a pain in the rear end. Okay, common cold, don't talk more about it. You can read through this. Upper respiratory, yeah. Absence of school or work. My classes this time of year seem to have an epidemic. Sorry. Present company excluded because you're here. Okay, all of these, we talked about the viruses. Da 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 da. You can read that. You can read that. Well, I mean, it doesn't mean there aren't complications, but people with an immune system, and all of these are true, they can develop complications. Human to human, airborne droplets. The difference between a droplet, when someone has a cold and they call for sneeze, okay, it's out there. Within a couple of minutes, it drops to the floor. That's a droplet. Things like tuberculosis are airborne. They don't drop. They're in the air and they don't really dissipate. If there's ventilation, they will go out the window. That's why when you see in a hospital room with somebody who's TB, actively, they'll have an exhaust fan pulling that stuff out through a filter. There's a difference between a droplet. The other one that does it is hantavirus, the one that comes from rodent droppings in the desert Southwest. Airborne is tough. COVID is not airborne. It's temporarily in the air, but droplets mean they drop to the floor. Okay. Somebody walks in, they start stepping on it, they may be suspended again. So, I mean, you have to understand how things spread. We know about colds, no proven treatment, hand washing. And the bottom line for a lot of this is hand washing. Adenoviruses, the bad cold. Okay? More often, fever, more likely. Common colds don't feature fever. Swollen glands, sore throats, kind of looks a little bit like a strep throat. So that's where the confusion is. Lymph nodes, your mom would do this. My mom would do this back in the day. Are your glands swollen? Then they were more, because at those times we didn't have health insurance. You only went to the doctor if you were near death. I mean, if you were sick, you were going. Believe me, your parents didn't want you to get hurt, but my parents were ambivalent about that. You'll get over it, Lou, but I'm sick. Too bad. Go to school. But you have an idea of what's happening. And so all of these are potential problems. It's a little more severe, and the recovery time is greater. They thought about there's so many different strains. In the early days, they had thought about making a vaccine. It's always been discussed. I don't know. Environment for long, this is very resistant to a lot of things. Remember, these are naked viruses. This is how they work. And you can look through that. Again, humans, they persist in the environment. More problems in healthcare. And again, school children. If you like, as a lot of us do, to go in pools, whether they're community pools, if you're a pool owner, it's so important to make sure safety. Or if you have a hot tub, same deal. Any of those types of things. It's on you, because these can really be problems. I'll mention this ongoing a little bit more. We had an above ground pool when my wife, when her kids were home, she had 5 kids. Okay, and I mean, it takes a lot of care if you're a pool owner. That was a big above ground pool. We don't have that anymore. That's there. So you have to really be on top of all the chemicals that are in there. The chemicals are not fun, but I mean, you can't be spreading infections and things like that are there. And then really not a whole lot of treatment other than that. It's just more severe. Okay. I did not know this. For you folks with military, they get a lot of vaccines. You're familiar with that. My son, the first time from the Vietnam era, our country worked with Cambodia, who effectively we were at war with during the Vietnam conflict. He was the first one to go there and organize with their Navy exercise with our Navy. He goes, they sent me to Cambodia. He had to go to wherever the hospital was, to the base before he left. He said, I think my arms fell off. I mean, he just gave him some of these shots. It was amazing. Yeah, I don't know what they gave me. They gave me anything they had. Okay. So pneumonia is a disease of the lower respiratory tract. That's what we're getting to. I just want to introduce that. We hardly have any time anyway. This is a significant statement. Infectious diseases. This is not the same worldwide, but infectious diseases in this country, the number one cause of death is pneumonia. And that's going to be our topic on Wednesday. Lower respiratory diseases. It's unlikely we will get through it, but we will certainly get all of this chapter done by Friday, I am pretty sure. Thank you very much. Upper today, lower tomorrow and Friday, and then on to skin diseases next week. Thank you.